Hello, my name's Dr. John Rees. I'm a GP in North Somerset with a specialist interest in urology. The paper by Curtis Nichol and colleagues is very interesting. A post-hoc analysis of 4 papers looking at men with lower tract symptoms taking tadalafil to treat their lower tract symptoms in comparison with placebo over a 12-week period. It's a post-hoc analysis looking for a concept called minimum clinically important difference. This is the idea of a change, in this case in IPSS score, that would be detectable to a patient. And in the study they showed, they looked at a minimum clinically important difference of more than or equal to 3 points on the IPSS as being significant to patients, or a greater than 25% improvement on the IPSS. So the findings for tadalafil for both of those comparisons was very similar. It showed that about 2/3 of men taking tadalafil once daily had a clinically detectable, meaningful improvement in IPSS during the 12 weeks of the study. That looks quite impressive, but that's countered by the fact that about 50% of the men taking placebo in both comparisons again showed a clinically important change. Now I think, given the weaknesses of the study, it's a post-hoc study, it's over a short period of time, I think we can say that this is encouraging. We can say it's interesting to see papers that are actually looking at an outcome measure that's important to patients. Was the improvement in my symptoms of meaning? Was it large enough that I would wish to continue taking this tablet? Now in primary care, I speak from a primary care angle, when we treat men with lower tract symptoms, I think the men in front of us have those 2 questions in mind. Firstly, when we're deciding about starting medical therapy, for instance in this case for lower tract symptoms, firstly, is this treatment going to improve my symptoms enough that I'm going to want to carry on taking it? What proportion of men who take it will that be the case? Likewise, will I get side effects from this treatment that will stop me wanting to take it? And I think what we need is to move away just from the pure licensing studies, statistically significant changes versus placebo in a double-blind randomised controlled trial, and look for some more real-life studies measuring clinically important differences for patients. I would like to see a study for men with lower tract symptoms, predominantly set in primary care, randomised at the point of intention to treat, and randomised to standard treatment, for instance in this case randomised to either tamsulosin once a day or tadalafil once a day, and to study those men and to ask them questions, not just IPSS scores and symptom scores, but ask them questions that would answer the sorts of points that I made earlier. Was this treatment so good enough that you would wish to continue taking it? Did you get significant side effects? If we can see trials like that, I think it would make our job much easier in selecting appropriate medical treatment for patients.